Hello, my name is Jennifer Mills. I'm a current practicing medical laboratory technician and scientist. I'm also a certified phlebotomist. Today we're going to kind of go over a study that was made by Franzblau and Mauskar called Macrophage Activation Syndrome Complicated by Toxic Epidermal Necrolysis Following the SARS-CoV-2 mRNA Vaccination. So this paper discusses a case of a 23-year-old woman who had developed something called macrophage activation syndrome, MAS, as well as toxic epidermal necrolysis, TEN, as a result of receiving COVID-19 vaccination. MAS, that's when macrophages are grown, they're activated uncontrollably, they continue to grow and eat tissue, in essence. In toxic epidermal necrolysis, you're seeing this tissue being rapidly destroyed by the body's own immune system. And so this presentation is designed to discuss the case study of the 23-year-old woman, as well as additional patients they have identified that have had similar reactions post-vaccination. So this particular paper was basically a case study, and usually when they have case studies, it's the participating physicians or care team or folks that kind of worked with the patient through the duration of the symptoms, and they kind of write a paper to get a conversation going about whatever it was. So in this one, they had discovered that the SARS-CoV-2 vaccine, while having rare complications and is generally accepted as safe, this particular patient developed MAS, macrophage activation syndrome, shortly after the vaccine. Okay, and then on top of everything, she developed toxic epidermal necrolysis, TEN, which is a very serious immune response in which the tissue begins to die. So what's interesting is that she was previously healthy, she had no underlying conditions, so they kind of made a study out of it. Within the paper, they also included similar cases of symptoms that developed that kind of coincide with this patient, post-vaccination, of course. Now, what was learned overall was that something called CXCL9, which we'll get into, kind of peaked while symptoms were being aggressive. The study was based primarily on blood test results that identified other markers, not just CXCL9, and the patient's response to treatment. They did define that there are other cases that have shown adult onset Still's disease, AOSD, which lines up very nicely with MAS and TEN, after receiving the vaccine, and they've included those in this study as well. So we'll kind of take a look at the first figure of the study. Now I don't have it listed yet, we'll look at that in a moment, but the data is just blood tests through the duration of the patient's symptoms. It goes around 95 days. So the question being posed was, what are the blood results in the studied patient post-vaccination? They wanted to know if the pathophysiology of the young woman's patient immune system correlates with those lab results. The patient did develop the following symptoms immediately after vaccination: daily fevers, cervical lymphadenopathy, which is swollen lymph nodes, rash, nausea, vomiting, abdominal pain. Those are all common in immune responses. Tachycardia, fast heart rate, hypotension, so opposite of hypertension, so dilated vessels, and morbilliform eruption. So again, that goes along with the rash. Okay. So the figure, and I haven't shown it yet, and we'll kind of talk about that on the next slide, but what they learned from creating this graph and charting the blood results was that they align nicely with her symptoms. Okay, and so that helps us to decide what's happening inside the body while the disease is progressing. The lab results, again, we did standard venipuncture. We're using a medical laboratory and various technology techniques inside of those analyzers. Those include electrophoresis. We're talking ELISA. We're doing immunosorbent assays. We're doing some of the chemoluminescence with our CBC analyzers. So kind of all of the above as far as technique. Okay. And then what was remarkable is that the leukocyte count obviously was pretty high. So when you get high white blood cells, you're thinking, okay, they have a viral infection most of the time in a medical laboratory. Not so in this case. We're thinking an immunology response because she does not have the virus. She's not infected with COVID. She just received a vaccine. Okay, so she had a very high leukocyte count. Okay, what's astonishing is that 93% of those are neutrophils. What does that mean? What does it mean when almost all of them are one type of white blood cell? You're supposed to have, around 40% neutrophils, 30% lymphocytes, and then the rest little basophils, eosinophils, stuff like that. Those are the little allergy ones. Okay, so when you see a huge shift in the neutrophil land, you're actually looking at leukemia. Specifically, you're looking at CML, chronic myeloid leukemia. Okay, that is a marker that us med techs kind of see in our CML patients. So to see that this post-vaccination 23-year-old otherwise healthy adult is developing CML findings and her hematology findings is kind of interesting to me. Now, when you get going down the list, you're starting to paint a clinical picture. You've got decreased hemoglobin in this patient. Well, what does that mean? That means that she's not getting a whole lot of oxygen delivered to her tissues. It could be for any reason. She's got decreased platelets, so she might be experiencing some unwanted bleeding. Okay. Now, in any lab results, we're going to test your liver. So that's what these are: elevated liver enzymes, AST, ALT, AST and ALT is what we call them in the lab. If those are elevated, we know that they're in some kind of liver crisis. Now, when they're extremely high, we consider that liver failure. Okay. Now they were high in this patient. When we get into things like the extremely high CRP, it wasn't just high, it was extremely high. A CRP is a C-reactive protein. That's an inflammation marker. So she had some extreme swelling, potentially of the internal organs. And then that releases this protein into the blood that we can test for. Now hers was pretty high. It was 186.1. Normal is less than 5. So well, we've got an immune response going on. Okay, as we know, inflammation is very, very tightly related to the immune response. Okay, so when you're a physician trying to figure out what's going on with the patient, you're thinking, okay, was it a dirty needle? I mean, did they clean the site before injection? Did she just simply get an infection? Did it have anything to do with administration? Did she have a previous infection that just decided to go wild after the vaccine? So, your physician's going to take blood cultures. Blood cultures are a blood draw where they put blood in little bottles. They're going to put them on an incubator and see if bacteria grows. Okay, they were negative. So this has nothing to do with an infection. So our CRP is elevated, and yet the patient does not have any kind of infection. Okay, so we're still in the immune system land. She did have an extremely high ferritin. What is ferritin? That is something that transports iron. Okay, so it binds to iron, transports it around in the body. We can test for that. We can also test for iron as well, but clinicians prefer to kind of look at the transport binding form of iron. Okay, it's extremely high in this patient. And in fact, I'd hate to be the tech that was testing this blood because they probably had to dilute it 50 times before they were able to pull up this number for the analyzer to read it. Her number was so high, it was 56,131 ng per ml, milliliters of blood. Okay, so the normal is between 5 and 204. So what does that mean? That means the body is not breaking down iron. It's just voraciously collecting iron. The liver is not able to process this iron. That's where everything happens. The liver processes and binds iron, sends it out to where it needs to be stored. Okay, it's not working. So something else the liver does is it deals with the triglycerides. Okay, it packs fats, it processes fats, it stores fats, and it helps the whole metabolic process move along. Well, it's not doing that either. Her triglycerides are so high, we usually associate that with coronary heart disease. So someone who isn't exercising, eating way too much fatty food, their triglycerides are going to be high. Those folks are around 2 to 3, sometimes as high as 400. This is double that. This is 811 milligrams per dl. So she's in some kind of liver failure crisis. Okay, that's a very high result. So here's finally our immunology markers, right? We've got an extremely high interleukin 18. That is a specific immune system marker. It's a glycoprotein that white blood cells make to help the body react in an immune response. Well, this one is so high that it's at 181,803 pg per milliliters. Okay, the normal for normal healthy functioning body is 89 to 540. So that gives you an idea how high this was post-vaccination. And then she also had an extremely high CXCL9, which is kind of the highlight of the whole study. They're finding in patients that have had severe immune responses after vaccine, the CXCL9 is very, very high, especially in relation to the necrolysis of the tissue. Okay, they found that it was 548,075 pg per milliliter. Now the normal is less than 647 in a healthy immune system. So let's kind of look at our next slide so you can finally see the graph. Okay, so here's the bread and butter of the case study, the findings. This is seen in the figure 1 lab test results chart that they had made. So right off the bat, the first thing you're going to notice is that CXCL9 marker that they've identified in this patient and in many of the other patients they talk about. What is that? That is CXC motif. It's chemokine ligand 9. It induces chemotaxis, and remember chemotaxis was inflammation that causes white blood cell proliferation. So the tissues are getting inflamed. Here comes the white blood cells, then they start rapidly dividing, multiplying, and in necrolysis, it doesn't stop. Okay, so that was really high post-vaccine, and you can see it kind of peaked around, day 35. It was high immediately when she finally started being tested, it looks like on day 18 when she was admitted into the hospital for testing. And then it kind of dropped. Okay, so it looked like you can kind of see all the levels are dropping back down to normal. Normal would be anything kind of down there at the bottom for your ferritins, WBC, CRP, all that kind of stuff. So their bottom baseline of this chart is designed around all the normal values for those tests. Okay, remember we got ferritin, that's the iron transport test, and then your AST, that's for your liver. LDH, lactate dehydrogenase, that's another chemistry test. Okay, and then there's that IL-2R and the IL-18 and the CXCL9 there on the legend. And you can kind of see they spike all of a sudden on the onset of the rash. So that kind of helps us narrow down what's happening in the body with an immune response, especially with onset of necrolysis. Okay, in case you didn't pick up on what the toxic epidermal necrolysis is, TEN, it is a rash. It's an immune disease rash specifically, where the body starts attacking its own cells, and you can see that as evident with the rash on the body. It's a very specific rash. This is the photographs of the 23-year-old woman in the case study. So there was another figure that the study had included, and it's because they wanted to discuss other patients that are having similar reactions post-vaccination. So they were looking at things like age, gender of these other patients, if there were any pre-existing conditions, what kind of vaccine it was, how long after the vaccine the symptoms began, the type of inflammatory response, was it necrolysis, was it MAS, all that kind of stuff, and the treatment and response that they had to use in each case. So what they learned using this data was that most of them didn't have any pre-existing or underlying conditions. The range is usually around 5 to 14 days. I think there was one that was 3 months post-vaccine. That one's kind of iffy. But, typical immune response. After the body gets a virus, it takes around 7 to 14 days to fully develop full-blown symptoms. All of these patients that developed the immune response after vaccination, they all developed inflammatory immune responses. Okay, and so here's that chart of all the other patients they identified and we're working with. I realize it's probably kind of small to see, but again, they're just listing all the patients so that you can see that it has nothing to do with age in these cases. Some were young, some were older. Many of them did not have any past medical history. They kind of list which ones, AstraZeneca, Pfizer, Moderna, and they kind of list all the symptoms. Almost all of them were AOST. The treatment is naproxen, usually. It doesn't really give the prognosis of what ended up if the patients recovered, but it was just kind of meant to lay out the data. Okay, and then here's that chart continued, and then they've got all of their the folks that helped them put this chart together listed there. And it just kind of gives a nice little idea of how many other patients there are, while small, a small list so far, still worth looking into for an immune response study. Okay, so in summary, the case study was kind of a fun little thing to read. Even the writers acknowledge, while extremely rare, the research does prove that there is a relationship between receiving the vaccine and immune responses. But that's the point of vaccination, right? You're purposely trying to elicit immune response. Normally, they're in your favor. However, in this case, some of our patients that received the SARS-CoV-2 vaccination did experience extreme autoimmune responses that could be fatal if left untreated, and that's what the study was kind of covering. So that kind of brings us to the end here. They kind of pose the question of which patients are truly at risk for developing autoimmune responses after vaccination. It's been widely accepted that people with pre-existing conditions or underlying conditions are those that would develop any kind of severe reaction. But this research suggests otherwise, that also healthy individuals are at risk. So it gives the question that additional research should be conducted to understand genetic, maybe chromosomal makeup of these otherwise healthy individuals, so we can identify, even if rare, who is more likely to develop such extreme reactions.